Okay, we should be live.
Hey everyone, welcome to another session. Today we have Dr. Stewart. She's an orthodontist and she's going to be sharing some tips for us, her journey and like her daily life or anything else you guys may have questions about. So thank you so much for being here, and whenever you're ready, you can start.
All right, thank you. Thank you guys for having me and being here with me on this Friday. I'm excited to share a little bit about my journey to become an orthodontist, and hopefully it will be informative to you. And hopefully you'll learn a little something about dentistry that you didn't know before. So go ahead and get started. Again, I'm Savannah Stewart. I'm a practicing orthodontist in Jonesboro, Arkansas, which is in the northeastern corner of Arkansas. And if you couldn't tell, I am a Southerner through and through. I was born and raised in a town about 30 minutes from Jonesboro. I went and did all of my schooling out of state, and then now have returned home. So these are just some of the topics that we'll cover today. We'll start with a brief introduction to the field of orthodontics and a little bit about me and my education. And then I've kind of broken down some of the information I wanted to talk about into 5 W's. So we'll talk about the who, what, when, where, and why of ortho. I'll tell you a little bit about my daily practice life, and then we'll end with some advice that I have for you guys as dental students. And so, like I said, I was born and raised here in Arkansas. I did my undergraduate training at Arkansas State University, and in 2012, I graduated with a Bachelor of Arts in Chemistry and a minor in biology. My last semester of undergrad, I was accepted to the University of Missouri in Kansas City for dental school. And then a few weeks after that acceptance, I was actually diagnosed with breast cancer. And so following that diagnosis, I took a year off. I deferred my dental school at UMKC so that I could do my chemotherapy treatments. And I had several surgeries that I had to complete. And so during that time, my now husband had been accepted to WVU. And so I decided that I also wanted to apply there, and was accepted. And so that next year I went to West Virginia for dental school. And in 2017, I graduated with my Doctor of Dental Surgery degree. And then immediately following that, I matched at St. Louis University for residency in orthodontics. And in 2019, I graduated with my Master's of Science in Dentistry from SLU. So, and then following that, I went into private practice back in Jonesboro, Arkansas, as an associate doctor at Weaver Orthodontics, and I've been there ever since. My husband's also a dentist. He's a general dentist, and he jokes with me that I probably had one of the shortest orthodontic careers in history because, as you know, I started working in that office in January 1st of 2020. And then at the end of March, we were shut down because of the pandemic. So I had about 3 good months before we got shut down. But thankfully, you know, we're back up and running. We started back in May of last year, and we've been really busy. We had a really successful year despite being shut down for the 6 weeks. So really thankful for that, and I love being there. So next, we'll just get into just a little bit of an intro into orthodontics. And so, first of all, orthodontics orthodontics is one of the 12 dental specialties. So you have to go to dental school first, and then after dental school, you can apply to do a residency in orthodontics, which is anywhere from 2 to 3 years long. St. Louis's program was 2.5, so it was kind of that sweet spot right there in the middle. And what do orthodontists do? So we diagnose, prevent, and intercept dental and facial irregularities. And the official title is an orthodontist and dentofacial orthopedist. So as an orthodontist, I'm responsible for moving the teeth in the bone. And as a dentofacial orthopedist, I'm responsible for guiding the dental and jaw and facial development in my patients. And so Mainly what I'm doing every day is seeing people and sitting down with them and educating them on the problems and the issues that they have going on in their mouth from an orthodontic perspective, talking to them about what their goals are with their treatment and with designing their smile. And then we kind of sit down together and come up with a customized plan for them in order to achieve those goals. And so now we'll just go over a little bit of anatomy of braces. I'm sure a lot of you have probably had braces in the past, and so you probably know, and this will be a little bit of a review. But for those of you who aren't familiar, let me just kind of orient you here. That way you aren't confused through the rest of the presentation. So on the teeth, you can see these little metal squares. Those are the braces. We call those brackets. And the brackets can either be glued directly on the teeth like they are here on the front teeth, or they can be welded to a metal band or a molar band that's going around the back teeth. So you see both types of brackets on this model. And so also you can see that there is a wire that's running through that bracket. So the brackets have slots in them for the wires to fit in. And in that slot, there's a prescription that's pre-programmed in there so that as we place the wires into the slots, we can tell the teeth to move based on that individual prescription. You can also see the elastic ties that are going around the brackets, those blue ties there. Those are what keep the wire engaged into the slot of the bracket. And again, we've already talked about the arch wire, but basically the way that braces move the teeth is that we bond the brackets directly to the center of each tooth, the crown of the teeth. And initially, especially in people that have a lot of crowding, teeth are rotated. And so the center of those brackets are not really lining up really well. So we'll have to start with a really flexible wire in order to engage all of the teeth. And then over time, as we start to straighten the teeth, we can work our way up into stronger, more rigid arch wires. Then you can also see on here the red circle is indicating or kind of representing what an elastic or a rubber band would look like. And those rubber bands are used once the teeth are straight and we're in those final finishing arch wires. We'll have patients connect these rubber bands to those little hooks that you see on the brackets, and that will direct the teeth, put force on the teeth to direct them to move in whichever way we want to correct their bite. And so in this patient, we're wanting to move the upper front teeth back and the lower back teeth forward in order to correct that bite problem that they have. And then in our office, we also do quite a bit of treatment with clear aligners instead of braces. And so Invisalign is a brand of clear aligners that we use. There's tons of different brands out there, but again, we use Invisalign. This treatment planning process is a little bit different than braces. So it all starts with, we take a scan of the teeth. We get that scan uploaded to the Invisalign website, and then from there, I am able to virtually treatment plan the case. So I'm able to put the teeth in whatever position I want them in to finish in. I'm able to kind of stage the aligners in whatever sequence that I'm looking for, and kind of treatment plan it all on the computer. And then once I get it everything where I want it, I send it off to Invisalign, and they will manufacture the aligners. Then they will send those aligners back to our office, and then we will deliver them to the patient. And so when we start, we're going to give the aligners to the patients. There's a few different steps in that process. So the first thing involves these red circles here that you see on these teeth on the picture on the right. Those are what's called attachments. So we will bond the attachments to the teeth, and those basically act as handles that allow us to move the teeth whichever direction that we want. It also helps us keep the aligners seated down on the teeth. So each Invisalign case will definitely have some aligners, some will have attachments, some will have more attachments than others, just depending on how much tooth movement there is to do. And so once we get the attachments glued on, we'll deliver the trays to the patient. They will take their first 6 to 8 trays home with them. They will change each tray once a week. So they wear each tray or liner for 7 days, and then they will switch. And then at the end of that 8-week period, they come back, we check to make sure that everything is fitting well, and we'll give them their next set of trays. So the same thing with aligners. They can wear rubber bands. Basically, you can do everything that you would be able to do with braces. You're able to take them out to clean your teeth, to brush your teeth, to floss, and so it makes hygiene a lot easier. It's just more of an issue of compliance because the aligners have to be on the teeth for at least 22 hours a day in order to get the movement that we need. There's just a little bit of movement in the aligners, and then over time, after they're all finished with their treatment, their teeth should be straight and the bite should be aligned, just like it would be with braces. Okay, so now we'll get into the 5 W's of orthodontics, and this is just something that I came up with as a way to kind of organize some of the information I wanted to share. So the first W is who. So who do orthodontists treat? Well, obviously we treat patients that want to improve the aesthetics and or the function of their smile. In our office, we limit these patients into one of 3 categories. And so first category would be an interceptive or an early treatment. The second would be a limited treatment. And then the third would be a comprehensive treatment. So we're going to go through each one of these divisions, and I'll give an example. So interceptive treatment is for patients who are in mixed dentition. So mixed dentition means that they have some baby teeth or primary teeth present, and then they also have some permanent teeth or adult teeth present. And the main goal in these cases are to kind of intercept problems that are going to cause more problems as the patient develops. And we also want to guide their growth and development for any patients that we can spot that are having issues with their jaw growth. And so we treat them. A lot of these patients have the 6-year-old molars or the first molars present, and then they'll have the incisors, the 4 permanent incisors present. And then we'll take the braces off, we'll give them a retainer to wear, and then we'll continue to monitor them until the permanent teeth erupt. And then typically when the permanent teeth erupt, most people still need a second round of orthodontics to treat all the teeth comprehensively. And so sometimes this early treatment is referred to as phase 1 because they'll have an early phase or phase 1 of braces. We'll take them off, monitor and observe, and then we'll do a second phase, which is called phase 2 after that. So this is an example of a phase 1 or early orthodontics case. So as you can see, the before pictures are up here on the top. And so this is a patient that has a mixture of permanent and primary teeth. So the back molars back here are both permanent. The 4 incisors, upper and lower, are permanent teeth. And then the whiter teeth are primary or baby teeth. And this patient has an issue that's called a unilateral posterior crossbite with a midline shift. So if I look at the dental midlines, you can see the upper midline is a little bit to the patient's right, and the lower midline is a little bit to the patient's left. And then on the back teeth, you can see the lower back teeth are kind of coming out in front of that upper back teeth. And that's what's called a crossbite. On the right side, you can see that the upper back teeth are overlapping those lower back teeth, kind of like a lid fits on a jar, which is the relationship that we want. Crossbite, again, is on the left, and that's not great. And we do like to treat these early on because these are one of the issues that can cause problems as the patient develops. So it could cause, if the permanent teeth come in this position, it could cause jaw asymmetries to form. Also, whenever the teeth are coming together improperly, you can get excessive wear of the enamel on the teeth, which, for the primary teeth, it's not too big of an issue, but for the permanent teeth, we really want to keep that enamel as strong as intact as possible, because once it's gone, it's really, you have to replace it with a filling material. There's no way to get it back. And so for him, we decided to go ahead and treat him with a palate expander. And I'll show you what one of those look like in just a second. Sorry, I don't have any pictures of him in treatment, but we'll do a palate expander. That will expand the upper jaw. It will also expand the upper teeth, and it will correct that crossbite. So you can kind of see on On him, we did that expander. We also put braces, what's called a 2x6 or 2x4, where we align the front 4 teeth with braces. And then we also put braces on the back first molars after the expansion, just to get everything lined up. And so you can see on the after picture that crossbite is totally corrected. The upper 4 incisors have been aligned. The midline looks a little bit better because we didn't treat the lower arch. That's not totally perfect, but we'll go ahead and perfect that in the second phase of braces, and he's good to go. He's not going to have any unwanted wear to those teeth anymore. We're just going to watch him until he gets the remainder of his permanent teeth in, and then we'll start thinking about doing a second phase. Okay, so the next category that we treat in our office is what's called limited treatment. And this is for people that are only interested in correcting a specific problem. And so we do not treat all the permanent teeth. It's just limited to a single area of the arch or a single arch. So meaning upper braces only or lower braces only. And it may only be an active retainer. We may not even be using any brackets or aligners. And so this is a case that I just finished a few months ago in practice. You can see here that this patient has got a lot of crowding upper and lower. She's also got what's called an anterior crossbite, where you can see this lower right canine is kind of coming out in front of that upper right lateral incisor. And this patient, for whatever reason, was not interested in getting anything done to her lower teeth. She just wanted us to straighten her upper teeth. So that's what we did. We put braces on her upper first molar to first molar. We got everything straight on the upper, and then we took her braces off. So as you can see in this final photo, we did nothing to her lower teeth. Her lower teeth are still crowded. We did nothing to correct her bite, other than we did get her out of that anterior crossbite. And then you can also see in this picture that unfortunately this is what happens whenever people do not take really good care of their teeth and don't have proper hygiene with the braces on. You can see in some of these areas she's got what's called white spot lesions, which are scars that can eventually lead to cavities. That's kind of that initial breakdown of the enamel structure. So this is an example of a limited case. And then finally, we also do a lot of comprehensive treatment on people that are interested in correcting everything. We put full braces on all the permanent teeth. We'll include both upper and lower arches in treatment. And basically the goals are to get everything as perfect as possible. So we want to align the teeth and improve the aesthetics of the smile. We also want to achieve a good occlusion, which is the bite, and improve the facial aesthetics by adding, lip support to their lips. Also, in growing patients, we're able to kind of guide the growth of the jaws as well. So this is an example of a patient that I treated in residency at St. Louis University. So there's a lot that we can look at on this case. So the first thing you'll notice when you look at the individual arches is that he's got a little bit of crowding on the upper and on the lower. You can also see, again, that he's got that crossbite tendency on the right side where those lower teeth are out in front of the upper teeth. And you can also see that his lower midline is shifted over to his right side, just like on that first patient we looked at. And then also when I'm looking at how the teeth come together, all of his upper teeth are kind of ahead of his lower teeth. And we call that a class 2 malocclusion. And so it's got a bite discrepancy in the anterior posterior dimension with all those upper teeth ahead of the lower. And you're also seeing that tendency on the front teeth as well. He's got what's called an overbite, where the upper and lower front teeth are overlapping too much. And then overjet, which a lot of people will refer to as overbite, but it's actually overjet, is that there's an excessive distance between the upper and lower front teeth as well. And so for him, we did another palate expander, which this is what an expander looks like. And we did that in order first to correct that posterior crossbite that's present. And so this is an expander, a Hyrax expander. It connects to 4 of the back permanent teeth. So 1, 2, 3, 4. And then you can see there's a little hole kind of in the middle of this expander. And we will send the patients home with a little key, and they will ask them to turn 1 to 2 times a day for typically a week to 10 days. They'll do those turns at home, and then they'll come back to us and we'll check their bite, and we'll either tell them to keep going or we'll tell them to stop and we won't turn anymore. Once we're finished turning the expander, we've got the correction that we want. We'll leave that in place for about 6 months, and that just provides stability. It gives the bone time to fill in between the 2 halves of the upper jaw. Something else I want to point out on him is that you can see this space that's opened up between his front 2 teeth, which if I can go forward or back a little bit, that space was not there before, and now it is. So that is a good sign to me that what's happening is the maxilla or the upper jaw is being split into 2 pieces, which is what we want to get that expansion. Okay, so after we did the expander, we put the full braces on him. You can see on this upper teeth, they're all connected together by an elastic chain. That's called a power chain. And you can also see that we're addressing his bite discrepancy with rubber bands. So like I said, his upper arch and upper teeth were all ahead of the lower. So we're wanting to orient the bands in a way to bring those upper teeth back, to bring those lower teeth forward. I will point out on him as well that we did not treat his second molar. So you can see back here, it's hard to see because his cheeks are kind of in the way, but you can see we don't have any appliances on those very back teeth. That is not something that I do in practice. In practice, I like to put brackets and have appliances on every permanent tooth that I can, just because it gives me a little bit more control whenever I'm correcting the bite, but that's not something that we treated on him. And then this is the final result here. So you can see all the teeth are straight, except for these second molars, which drives me nuts that we didn't treat, but all the teeth are straight for the most part. You can see that the crossbite has been corrected. The upper teeth are fitting over the lower teeth, kind of like a lid fits on a jar. So that's the relationship that we want. You can see in doing that we've corrected his dental midlines too. Both midlines are lined up. And if we could see a picture of his face, we would see that they were sitting right dead on his facial midline as well. We've also reduced the overbite and overjet. So we've given him a good bite. And I'll point out on him that you can see, I hope you guys can see how flat the edges of his back teeth are, especially on the side that he had the crossbite on. And so this is one of those cases that he probably had the crossbite whenever he was younger. And then for whatever reason, he chose not to get it corrected early on. We kind of waited until he was older. And now we've seen that excessive wear of the permanent teeth. And there's really not a lot that we can do to get that back unless he wants to go and have some restorations placed by his dentist. So that right there is a great example of why we recommend early treatment for crossbites. Okay, so moving on to the next W, what are the orthodontic treatment options? And this list is pretty much endless. I'm going to go through hit a few of the major options with you, but just know that there's tons of them out here. We'd be here all day if I was to try to describe all of them. So traditional metal braces is what we've just covered, what you've just seen from that previous patient. We also have aesthetic brackets, which a lot of our older teenagers and adults are interested in now. It may be a ceramic bracket, a champagne bracket that's kind of a more rose gold tint, or rhodium, which is a matte silver metal. I'll show you those here. And so these are the traditional metal braces here on the left. In the middle is the ceramic or the clear bracket. And then over here on the far right is showing you the difference between the champagne bracket versus a traditional metal. And then down here in the left is an example of, the bottom right is an example of aligners. We've also already talked about elastics that we used in order to help us correct the bite. And Other cases will also use other types of appliances as well. We've talked about palate expanders. There's also different types of fixed bite correctors for patients that do not want to wear rubber bands. We also will make TMJ splints for people that have issues with and have symptoms of joint disease. And we can also use headgear in patients in order to help direct the jaw growth. As far as retainers, once we take the braces off, there's all different types of retainers. Some offices will use Holly retainers, which are wire retainers. In our office, we use clear retainers that kind of look like Invisalign aligners. Those are called Essex retainers that we have our patients wear at night. There's also active retainers that actually move the teeth. And then the passive retainers are the retainers we use after braces or orthodontic treatment is complete, just to hold the teeth where they are. In more severe cases, we will sometimes use what's called temporary anchorage devices. That is the tiny little screw. It looks huge on the lower right here, but in real life, they're very, very tiny. And we will just use those in order to act as little anchors to help us move the teeth in whatever direction we want to. So those are used for people that have sometimes either have severe bite discrepancies or that have lost teeth, and we have a lot of movement that we want to achieve. Those can help us. Extractions, we do sometimes have to extract teeth whenever the cases are really crowded and there's just not enough bone to house all of the teeth. Sometimes we will elect to have the dentist remove some teeth for us to help align the teeth, to help align the bite, and also to improve the stability of the case after braces. And then there are some patients that have severe jaw discrepancies. And so in those cases, we will treat them with braces or aligners before, or we'll get all of the teeth straight, and then we'll send them to an orthodontic surgeon who will surgically kind of set the jaws in the right position for us. So we, try not to do that unless it's absolutely necessary, but I would say probably 5 to 10 cases a year in our office get treated with orthodontic surgery. And so the next W is when. When is the best time for orthodontic treatment? So the American Association of Orthodontics recommends that children first be seen by an orthodontist before the age of 7. And so 7-year-olds typically require no intervention at that time. Most of the time, we just choose to monitor them until they're a little bit more mature and more ready for braces. But what it allows us to do is identify any potential problems early on. So we can identify them early, and then we get the luxury of time to choose when is the best time to treat. And then once we've decided that they do need treatment, we're able to intervene at the best time for those patients. It also allows us to actively monitor them, monitor their growth and development. Sometimes we will send for extraction of baby teeth just to help things progress a little bit quicker, or we can also kind of guide the eruption of permanent teeth too. So healthy teeth are required before starting any orthodontic treatment. So we have to make sure that there are no cavities present on the teeth. We want to make sure that the tooth supporting structures are nice and healthy. So that would be like the gums, the bone, the joints. We want all of that to be healthy, and then we can put braces on the teeth. And so in growing kids, the most efficient and effective time to do braces is once all the permanent teeth have erupted. So sometimes we'll see patients in our office that still have 1 or 2 baby teeth, and they're really excited to get started. And we will sometimes go ahead and get started, but really it's the most efficient. So I'm able to get the most done in the shortest amount of time. If all the permanent teeth are already present, we can put braces or appliances on them all at once and get started. With adults, they can be treated obviously anytime there is a desire or need for treatment. A lot of times these cases are what's called multidisciplinary, which means that we're working alongside of their general dentist or another dental specialist to help them reach their goals. A lot of these cases are limited to correction of a specific problem. So it may just be treating the upper front teeth, or it may be treating upper and lower, but only the front teeth and not the back teeth, something like that. And we have adult patients that are all the way up into their 80s. So treatment for adults is definitely becoming more popular now than it used to be. And so the next W is where, and there's a lot of information on this slide, but I wanted to include it because I feel like that this is an area of confusion for a lot of people. So where do patients go for their treatment? So number one would obviously be going to an orthodontist. An orthodontist is a practice that's going to be limited to orthodontics. So as an orthodontist, that's all I practice. I don't do fillings. I don't do root canals. I don't do extractions. I only do braces and clear aligners and orthodontics. So to be called an orthodontist, you have to have completed 2 to 3 years of a residency in the field. And during that residency, you're going to be trained in all areas of orthodontics. So braces, Invisalign. A lot of schools are teaching lingual braces, which are braces that sit on the inside of the teeth, not on the outside, or not the inside, but the tongue side of the teeth. You're trained in treating jaw disorders and everything that has to do with the field of orthodontics. There are a lot of general dentists that will also do orthodontics. And so a general dentist is anybody that's doing general practice. So they're doing fillings, crowns, extractions, basically all aspects of dentistry. And then they also will do some orthodontics too. Most dental schools will not train you a lot in orthodontics because, again, that's not typically a huge part of the general dental practice. And so most of their orthodontic training you have to get somewhere else. So they'll do continuing education courses outside after they graduate for dental school, and then can do after that. They'll a lot of times feel comfortable treating orthodontic cases. Most of them, my husband included, will treat with Invisalign. They'll do an Invisalign course, and then they'll start doing some aligners in their practice. Most of the time, they won't do any braces cases. There's definitely some that do, but like I said, mostly it's limited to Invisalign in the general dental practice. And then something that's more recent, that's become a little bit more popular are these do-it-yourself DIY companies that you've probably seen advertisements for, that are also doing aligners. And so in those cases, you either do an at-home impression where you take a mold of your teeth and you send it in and they make the aligners from that, or you can go into a building where you don't see a doctor or anything, but you see a technician who will take a scan of your teeth and they'll manufacture the aligners based on that. So in these cases, there's very little supervision by a dentist or an orthodontist, any kind of dental professional. You typically don't get any kind of x-rays or cleanings or anything like that. It's very limited treatment as far as supervision. And typically they will align the teeth, but they don't typically pay attention to the changes once you align your teeth and how that changes the bite. And so that's why I included that the occlusion is typically not treated. It's just to straighten the teeth. And it is a less expensive option than going to a dentist or to an orthodontist. And so that's one of the reasons that it's kind of growing in popularity. And then the last W is why is orthodontics necessary? So again, this is one of those topics that could go on for days and days, but I've kind of just included some pictures of some of the types of malocclusions that we treat. So obviously crowding, teeth are rotated. We can use appliances in order to straighten the teeth, which is what most people want. Again, with spacing, a lot of times we'll see spacing of diastema or space between the two front teeth, and patients will want us to close that. So that's something that we can achieve with braces or Invisalign. The crossbite we've talked about a lot, where the lower teeth are kind of coming out in front of the upper teeth, and that can be anywhere on the arch. So on this patient, it's a posterior crossbite, meaning that the back teeth are not fitting together properly. And then down here in the bottom right is an open bite, where you can see that there is no vertical overlap of the teeth. You're basically looking at that patient's tongue there. And then overbite, which we mentioned briefly as well, but that's when there's too much overlap of the upper and lower front teeth. An underbite is an anterior crossbite or a crossbite of the front teeth. Overjet is the excessive horizontal distance between the upper and lower front teeth. And then abnormal eruption is where you have teeth that come in a location that is not ideal. So on this patient, you can see that canine, that's what's called a buccally displaced canine, which means that it's on the buccal or the front side of the arch. Whoop. And so that would be an example of abnormal eruption. So moving on, like I said, I am an associate doctor at Weaver Orthodontics, and a lot of our marketing is we use the term Dream Weaver in our marketing, and so that's why I have included us down here as the Dream Team. And our office basically consists of two doctors. This is Dr. Weaver over here in the blue shirt, and then me standing beside him. And a funny story is that Dr. Weaver is almost 7 feet tall. He played college basketball at ASU in Jonesboro. I'm about 5 feet tall, which from this photo, I probably look a little taller than I am. He's sitting on a stool, and I am standing on about a foot high block in order to get this picture, and he's sitting down and is still taller than me. So anyway, there's just a little fun fact there. There's about 2 feet of height difference between us. So our office is the two of us. We have one office manager. We have 2 treatment coordinators who are responsible for presenting treatment and presenting finances to the patients. And they basically kind of just coordinate the treatment from the time that the new patient walks into the door until the time they get their braces on. We have one records assistant who's responsible for taking photos and x-rays and does all of our scanning of our teeth. She also takes impressions for us and makes all of our retainers. And then we have 5 chairside assistants. So those are the assistants that are they're helping get the patient set up, putting the braces on the teeth and cleaning off all the glue before the doctor comes over to check the positioning. They also will change wires out. So they'll take out the smaller wire and put in a larger wire at each appointment. They also can do some of our retainer deliveries and Invisalign deliveries. And then we have 2 front desk receptionists who are in charge of answering the phones, getting patients checked in and checked out. And our team, all of the people that are on our team are highly skilled at their jobs. In general dentist offices, the assistants are mainly assisting the dentist. They're getting things for the dentist to help them. And in our office, the assistants are really working a lot independently. They're all highly, highly trained, and they really are able to make us very productive. And you'll see, I'm about to show you kind of our statistics for our office, but they are the reason that we are able to do so much in a day. So here is some of the statistics that I was talking about. So in our office, I would say our breakdown is about 50% of our patients are adolescents, meaning that kind of teenager, early permanent dentition where they've just gotten all of their permanent teeth. We've got probably about 20% children, and that would be kids that are in mixed dentition, where a mixture of permanent and primary teeth, and then probably 30% adult patients, which would be 21 years and older. Most of the patients in our practice are treated with fixed appliances, so that means braces, any of those different types of braces, whether it be clear, metal, champagne. I would say about 70% choose the fixed appliances over the aligners, and about 30% are treated with the Invisalign aligners. And we typically see about 100 patients per day, which I don't know if you guys have shadowed in any dental offices, but in any general office, they probably see, I would say, no more than 40. And so 100 is a lot. We'll see about 8 to 9 new patient exams, people that have never been in the office before, and we'll meet with them, look at their teeth, kind of go over everything with them. We'll see anywhere from, probably about 5 observation patients. So those are patients that aren't ready for braces yet, but we're just observing their growth and development and their dental eruption. We'll see 5 to 6 records patients, which are patients that are getting the photos and x-rays done right before they're ready to start braces. we'll put braces or aligners on 3 to 4 patients a day. And so that's us sitting down and putting all of the braces on from start to finish on all of the permanent teeth. And then our bread and butter of our day is really doing a lot of arch wire changes where we're taking out their smaller wires and putting in larger wires. I would say we do probably about 60 or more of those in any given day. Aligner deliveries are where we just check on our Invisalign patients, make sure that the teeth are tracking well, that everything's going well with their aligners, and then we'll give them some new aligners. And then we'll do 2 to 3, sometimes 4 or 5 D-bands in a day. This morning, I think we did 6, and we were only there from 8 until noon. And D-bands are where we're taking off the appliances. So it may be braces, it may be the attachments from the Invisalign, whatever the case may be. And then we also do quite a few retainer checks. So this is for people that are out of braces, that are supposed to be wearing their retainers every night. We like to check on them 3 months, 6 months, and a year after the braces come off to make sure that they're, number one, doing what they're supposed to and wearing those retainers. We like to make sure that there hasn't been any unwanted tooth movement. And if there has been, we like to see them regularly so that we're able to intervene when needed. And so now the last part, I'm just going to give you guys some advice for applying to dental school. So the first thing is that you need a lot of exposure to dentistry. You need to make sure that, that you would like to be a dentist. You need to make sure, a lot of times dentistry sounds really good on paper. It's a good paying job. It's good hours. You don't have to be on call most of the time. So there's definitely a lot of perks to being a dentist. However, it's a difficult career. You spend a lot of time with your head down like this. You get a lot of neck and back pain. It's pretty rigid schooling in order to get to where you can practice dentistry. And so you really need to make sure that you're committed to it and that it's something that you think that you would like and would be interesting to you. So the way that you do that is, like here today at this presentation, you're getting a lot of good information, hopefully, and hopefully just by, doing the shadowing online, you're learning things that a lot of things probably the providers wouldn't even be able to share with you in their office. So I think that this is great. And then I would also encourage you to get out there and actually go into offices once hopefully the pandemic continues to die down and you're able to do so, because it's really important that you kind of get to see what the flow of things is like. And then I would also recommend that you go to specialist offices too. Just kind of try them all out, even areas that you think you may not be interested in, because you really just don't know until you get in there and kind of see what it's all about. So definitely shadowing is a good first step for your exposure. Then if you have the opportunity or have the time to work in a dental office, I did that in college, and that was super helpful to me. I kind of learned the ins and outs of insurance. And also learned a little bit about, assisting and how things ran in the office. So that was a great benefit. And then you can always also attend pre-dental days if you have any dental schools that are local to you in your area. And then once you decide that you think you really want to go to dental school and you really think that you would enjoy being a dentist, the most important part for you to focus on is academic excellence. So there is no substitute for that. Your grades and your DAT score is going to be what gets your foot in the door to increase your chances of getting into dental school. So you need a great GPA. I put 3.6 or higher, but honestly, just as high as possible. Just do your absolute best on all your coursework. And then you also need a great DAT score. When I applied, I think I had a 19, but I know that it's getting more competitive each year. And so I would say just, really study. You've got lots of good resources online now for the DAT. So just try to get your score as high as you can. And then once you've kind of got your foot in the door where you've impressed them with your GPA and DAT score. Something else I would recommend is make sure that you have lots of leadership and service on your resume and on your application. So, be a part of a lot of clubs on campus and then hold leadership roles within those organizations. They don't just want to see that you've been a member of something. Anybody pretty much can do that. Most of the time it's free, but it takes a little bit more work to be a leader. And that's a quality that they're going to want to see in future dentists as well. So hold some leadership roles and then also be involved in your community. Whenever you, most of the time when people apply to dental school, they all say, oh, well, I want to be a dentist because I want to help people. Well, that's great. But what have you done to show us that you really want to help people? And I think a great way to do that is to be involved in your communities with different philanthropies and things like that. With your application and your interview, don't just wait until the last second to apply. Apply early, kind of know a little bit about the application process. You're going to need letters of recommendation. So try to find people that you think would do a good job with that and give those people, if they are kind enough to write you a letter of recommendation, then you be kind to them and make sure that you give them plenty of time to do that so that they can do it well. And then also in your personal statement and during your interview, try to think of things that make you stand out. Most of the people that are there interviewing are all going to have good grades. They're all going to have a good DAT score. Like I said, that's what's going to get your foot in the door. So everybody's going to have that. You need things that will help make them remember you. And so try to include things that you think other people won't talk about. And then obviously be prepared. I don't know if you guys have looked into the cost of dental school, but it is outrageously expensive. I think at WVU, the cost of our tuition, and this wasn't even living expenses, was about $70,000 a year for out of state. And then plus residency on top of that was another $100,000. So, you're going to be in debt whenever you get out. You just need to be prepared for that, kind of understand that financial burden, especially if you have to take out loans. It's going to be more than that for your living expenses. So just kind of know that going in. And then whenever you get interviews, be prepared for those. Practice. Don't go in cold turkey. Just practice. A lot of times you can find courses that will kind of prepare you for that, or even some practice sessions through your college, which is what I did. And then make sure that you do research about each program, especially the ones that you really want to go to. Have questions prepared for them because a lot of you will be accepted to multiple schools. And so you're going to want to be prepared to make that decision as well. And then lastly, I would just recommend that you do something to develop your dexterity. So, working in the mouth, you're working in a pretty small space and you need to be very precise. And so something you could do is take an art class or a jewelry class that would kind of help increase your dexterity. Or if you have the opportunity to work or shadow in a dental lab, that would be great too. There was a guy that worked in a lab that was in my class and his hand skills were excellent. So that would definitely help prepare you. So that pretty much concludes my portion. I'm happy to take any questions if anybody has them.
Awesome. Thank you so much, Dr. Stewart. That was an amazing presentation. And we do have some questions from our YouTube and Instagram. Okay. So the first question has to do with the DIY companies like Invisaligners and just how they are getting very popular. And do you think they could affect job security in the future or anything with orthodontics in the future?
That's definitely a concern. And all throughout our residency, that was something that was always talked about. There's a few issues with that. And I think that as those companies become more popular and they start treating more patients, orthodontics is a complicated treatment process. And if there was an easier way to do it, orthodontists would be doing it. I absolutely promise you that. And so number one, that. Number two, there's a lot of things that we do with aligners that cannot be done by DIY companies. The first thing was those attachments that we talked about, bonding those to the teeth. You don't get those if you do any kind of DIY company because you can't bond that on at home yourself. And so a lot of times the teeth do not move very predictably with those. And so patients can end up having a lot of trouble just because there's nothing there. They don't have any of those handles to hold on to the teeth, number one. And then a lot of times, and I explain it to patients kind of like if you were to put your hand over a hot stove, your body's automatic response is to jerk your hand away. You don't have to think, oh, I need to move my hand. Your body just does that automatically. And same thing with your teeth in the aligners. If you put an aligner in your mouth that's trying to move your teeth will a lot of times kind of move up or intrude into your bones to kind of get away from that force and get away from that pain. And so that's why having those handles on the teeth or the attachments is 100% necessary in order to get a good result and achieve the desired tooth movement. The other thing that like I said, they don't consider anything with the occlusion or the bite. And so I've also seen a lot of people that have been treated by these DIY companies that are having significant problems chewing and eating, and it's really kind of disrupting their daily lives. So I really don't think that, I haven't seen in our practice that there's been a whole lot of decline because people going more towards DIY companies. I really think at this point, there's a lot of issues that are taking place and that are going to continue to take place the more popular they become. And so it'll be interesting. I know that the AAO has kind of taken a firm stand on that about how they disagree with that because there's no supervision hardly at all. And so stay tuned. But I think that the profession of orthodontics should not be too affected.
Awesome. Thank you. So another question, somebody asked had to do also treatment planning. So after braces, how long does the patient have to wear retainers typically, or is it just like forever?
Mm-hmm. Yeah, this is a popular question. I get asked that at least once a day. And what I tell people is that you wear your retainer at nighttime as long as you want your teeth to be straight. And so throughout our lives, it doesn't matter if you have your wisdom teeth, if you don't have your wisdom teeth, the tendency for the teeth is for the teeth to shift. And I wish that there was something that as an orthodontist I could do to prevent that, but honestly, there's just not. And so we recommend that the first year is the most crucial. So 12 hours daily wear for the first year. We have people brush their teeth after they eat dinner, put them in, wear them all night long, and then take them out. After the year time period, they can go to nighttime wear, which would just be 6, 7, 8 hours a day, where after that I will tell people that you can sometimes get away with every other night if you're careful, but you really need to have retainers on hand to wear at nighttime for the rest of your life if you really want to protect that investment and keep your teeth straight. We also will do what's called fixed retainers. Some people will call those permanent retainers. We bond those to the inside, the back of the lower front teeth, and sometimes the upper front teeth too, because those front teeth are the smaller teeth in the arches, and they're the most likely to shift after braces. And so in patients that have good hygiene, that have taken care of their braces and are good candidates for those, we will offer those to our patients for no additional charge.
Awesome. Thank you. So the next question kind of has to do with, like, when you said 100 patients a day, I was very surprised. So I'm just kind of curious, like, how does the office dynamic work? Like, how many patients will you be seeing, like at once, or like just kind of going back and forth, or how long are you with each patient?
So we have, like I said, we have those 5 clinical assistants or chairside assistants. We have 6 active patient chairs, and at any given time, they're all filled. So there's one overflow chair, and then each assistant runs their own chair. And then we also have the records room, which does not require any doctor time. So the patients that are there for records, they get their photos, they get their x-rays, they leave, and then I review all of those records once they are gone, just whenever I have time. And then we also have the new patient room, which has our treatment coordinator in it. He's talking to the new patients, and they will kind of come and get me and let me know when they're ready to be seen. And so there's a lot going on. I mean, it's like constant in and out. And like I said, each assistant is responsible for their own chair. We have one assistant who is termed clinic coordinator. And so a lot of times when Dr. Weaver or I come out of that new patient exam room, she is showing us where to go. Okay, this is going on in chair 1. This is going on in chair 2. A lot of times it's just simple arch wire changes. So I put on my gloves, I get the mirror, take a look, make sure everything looks good. The assistants have already done their work. And so they're already ready to go. There's also typically a bond going on where we're putting braces on for the first time, kind of have our own little sequence that we do. And so those assistants are placing the brackets, and then once they have them placed, they come and get us. We are making sure they're in the correct position, cleaning off any excess glue, and then curing the brackets in the position that we want. Then we'll go away to see some other patients, and they'll put the braces on the back teeth, and then we come back. So it's kind of just a constant flow, super fast paced. There are days that I do not sit down at all, just constantly go. But, it's great. It makes the days pass a lot faster than it is just sitting around waiting on something to do. So.
Absolutely. That sounds amazing. So the next question kind of has to do with treatment planning. So how does that look exactly for your office specifically? Like, how does the treatment planning session go, and what's kind of discussed when doing that?
So are you talking about like our new patient exams where we're meeting somebody for the very first time and we're discussing treatment options?
Yeah, exactly.
Okay. And so they come in, like I said, the treatment coordinator kind of gets to know them. She'll come and get me and tell me all about them. You know, this patient is 10 years old, goes to this school, mom with their name is with them. And so she kind of briefs me before I go in and I kind of ask them a few questions just to get to know them a little bit, and then take a look at the teeth. And pretty much when I look at the teeth, I have a very good idea on most cases what we're going to be doing. It's pretty standard, I think you'd be a great candidate for braces. I think you'd be a great candidate for Invisalign, or I think you'd be a great candidate for either one. The choice is yours. I kind of lay out, here are the issues that I see, A, B, and C. Here are how I would recommend that we address those issues. Here are the consequences if we do nothing. And this is what's going to occur over time if we don't treat them. Sometimes there's, with the bite correction, like I mentioned, there are some appliances that are fixed in the mouth, or there are rubber bands that we can use to correct the bite. And I'm talking about for people that have fairly significant bite discrepancies. A lot of times the parent will say, well, I know from them, they don't do their homework. I have to stay on them about doing anything extra at home. And so I really don't expect that they're going to be responsible enough to wear the rubber bands, to put them in, take them out after every meal and wear them 22 hours a day. So let's just do something that's kind of glued in that they don't have to worry about that. So sometimes it's, talking with them about the personalities and, what the parents would prefer for us to do. So we just kind of sit there and have that conversation. And then most of the time, we're pretty much 99% sure exactly what's going to happen. Now, there are some cases that have very significant, like I said, jaw discrepancies, bite discrepancies. They have a lot of crowding. And so in those cases, I will kind of give them my initial thoughts, kind of explain the sequence of what I would recommend. And then I'll say, but hey, we're going to get these records, which are going to be 2 x-rays, going to be photos of the teeth and a scan of the teeth. And I'm going to need to go and sit down and do a full case workup where I'm tracing their lateral step. I'm I can do digital setups on my computer where I can, if I'm thinking, well, maybe we should remove these teeth, I can remove the teeth and I can play around with the final tooth positions and see which option that I like better. And so there are some cases like that I really want to take a little bit more time with. And so I will do that. And we'll get the records. I will come up with a specific plan, and then we'll sit down and meet again, and we'll go over that specific plan.
Awesome. That sounds wonderful. So the next 2 questions have to do with residency. So away from practice. So how did a day in orthodontist residency look like for you? Like a day in your life?
So at St. Louis U, and all residency programs are different. They all have different treatment philosophies. St. Louis, you pretty much learn from a ton of different doctors. I think we had about 50 faculty members, and we had cases with all of them. And so back to your question, whenever we got there, we did what was called a orthodontic boot camp. So in dental school, like I said, you really don't get a lot of exposure to orthodontics because that's not going to be your main focus as a dentist. Your main focus is going to be doing extractions and fillings and restorations, crowns, things like that. So whenever we got there, they really focused on teaching us the basics of orthodontics. So we did that for, I think, 6 weeks or so. And then once we kind of graduated from that course, we got to start seeing patients. So they would give us our patients. We were responsible for pretty much every day. We had class from 8 to 9, and then from 1 to 2, I think. Basically 2 hours of class a day, and then we saw patients the rest of the time. So it was a lot of hands-on learning. So we would get patients, they would be assigned to a resident, which was obviously me, and then a faculty member. Like I said, we had about 50 faculty members there at the school. And so we would take their records, take their photos, x-rays, all of that. We would send them home, and then we would sit down with the faculty member that was treating the case. We would come up with a treatment plan. Once we had that plan, we would bring them back, and the parents we would sit down and discuss the case with the parents, and then we would go ahead and put the braces on. So at the beginning of residency, we were seeing maybe 2, 3, 4 patients a day. Most of them were records. Then as we started putting braces on people, we were doing more bonding appointments. And once we got all the braces on, the majority of the people, we were doing mostly arch wire changes. But it was still a little bit of, we didn't have control of our schedule, but it was still a little bit of mixture of appointments all in. You might do 1 bond in a clinic session, and then the next clinic session, you might have 3 arch wire changes. But like I said, we still took classes for the entire 2.5 years, and then the majority of the time was spent on patient care. We also did in some residencies, if you get a master's, you have to do a thesis. And so our program is one where we did do a thesis project as well.
Awesome. That sounds wonderful. So I think we have time for like one more question. It's also just related to like residency, but like once you completed your residency, how hard or difficult was it to find a job in the field, or was it fairly easy?
I think that is more of a regional issue. I had no problem finding a job. Jonesboro's a pretty small town. It's about, I would say, 70,000 residents in the town of Jonesboro. But like I said, I was kind of born and raised in this area. So I knew a lot of people. I knew pretty much my parents still lived here. So I knew of all the opportunities. And the Dr. Weaver, who I'm practicing for, I had started talking to him while I was in dental school. So I pretty much had this job lined up from the time that before dental school graduation, I should say. Now, I've had friends in other areas of the country that have had difficulties finding jobs. One of my friends from dental school is in the Pittsburgh area, and I know it took her a few months. But that's one of those things that, kind of plan. The earlier that you can plan, the better. I mean, obviously until you're 100% accepted into residency, it's kind of hard to plan. I was just lucky that that all worked out in my favor. But yeah, I mean, I think that finding a job shouldn't be too difficult, but there are a lot of residency programs that are taking a lot more applicants now. And so it may be a little bit more difficult now than it was, back 10 years ago, but still doable.
Awesome. So that's all the questions we had for today, and that's our virtual session. Thank you so much again, Dr. Stewart, for the wonderful presentation and question and answer session. We all really, really appreciate it.
Yeah, thank you for having me. It was nice meeting everybody.
Of course. Thank you. Have a wonderful rest of your day.